All right, well, thank you everyone for coming. We're so excited to have you all here today. Today we'll be discussing a wide smattering of topics. We're going to talk about Epstein Barr virus and how it relates to multiple sclerosis. We're going to talk about a prodrome and what that is, and then early and aggressive treatment. What is Epstein Barr virus? Epstein Barr virus is a herpes virus. It causes a wide array of symptoms. People can be asymptomatic. You could have a cold. You could have mononucleosis, which is the kissing disease that people got in high school and college. It is associated with other more scary things, including lymphoma, and we also know it is associated with multiple sclerosis, and that's why we'll be talking about it. So how does Epstein Barr virus relate to multiple sclerosis? We know that autoimmune diseases can be triggered by viral infections. Things like Guillain-Barré syndrome are triggered by viral infections. We also know that antibodies against Epstein Barr virus, specifically this Epstein Barr nuclear antigen IgG, are present in nearly all patients with multiple sclerosis. And we know that symptomatic mononucleosis can increase the risk of developing MS. What's more is EBV is found in some MS lesions on pathology studies. So that sounds all pretty good. It sounds like it's a slam dunk that Epstein Barr virus is associated with MS. The problem is more than 95% of adults have been exposed to Epstein Barr virus at some point. And it's really hard to show that there is actual causality that Epstein Barr virus causes MS. So how do we study this? You have to go and do an experiment of nature. So basically, you have to look at people that don't have Epstein Barr virus and see what happens when they go on to develop Epstein Barr virus. So Harvard decided to look at this, and they collaborated with the US military for a 20-year study looking at more than 10 million individuals in the military. And the military is actually a perfect place to look for MS and Epstein Barr virus because they're young individuals, people that are 18 and 19 that sign up for the military. And they collect blood on everyone that joins the military. They look for various infections like HIV. And most of these individuals get multiple blood tests throughout the course of their service. So many of these people have 3, 4, even more serum studies or blood studies. So over 62 million serum samples were analyzed for Epstein Barr virus in these 10 million individuals, and they found that 5.3% of individuals did not have Epstein Barr virus at the time that they were first screened, when they first joined the military. They then looked at people that went on to develop Epstein Barr virus. They were originally negative, and then they became positive during their service. What they found was that Epstein Barr virus absolutely increases the risk of MS. People that did not have, that were Epstein Barr virus negative, and then went on to develop multiple sclerosis, nearly all of them converted to become Epstein Barr virus positive. This is in comparison to people that did not develop multiple sclerosis. Still many people went on to develop Epstein Barr virus, but only 57% of people developed Epstein Barr virus compared to nearly every single person that developed multiple sclerosis. That means that there was a 32-fold increased risk of developing multiple sclerosis after getting infected with Epstein Barr virus. This is pretty big, and the first time that there was really something that showed that there could be a causality component to this. And this just came out in 2022, by the way. This was a big paper in Science. So how did they know it's just not just infections in general, that other viruses aren't causing multiple sclerosis as well? They looked at CMV, or cytomegalovirus, and they found that when people were CMV negative and went on to develop CMV during their service, that those people were not more likely to develop MS compared to not having MS. They even showed that people that were baseline positive for CMV actually have lower incidence of multiple sclerosis, and they think that CMV may actually attenuate or decrease the negative effects of Epstein Barr virus. They then went and continued to look at other viruses. So they took 30 people that have MS and 30 people that didn't have MS and looked at they looked at over 200 viruses and looked to see if they had antibodies against those viruses. They kind of did this fancy assay. And the only virus that was associated with developing multiple sclerosis was Epstein Barr virus. And that was both before their official diagnosis, but as well as after their official diagnosis. They also went and looked at a marker called serum neurofilament light chain. So serum neurofilament light chain is a hot topic in multiple sclerosis. It's a biomarker that shows neuroaxonal damage, so damage to the central nervous system. And it's not specific to multiple sclerosis. It can occur with other diseases. But they showed that after developing Epstein Barr virus, people were more likely to develop damage to their central nervous system with increase in their serum neurofilament light chain. Now, people that didn't have MS after they got Epstein Barr virus, these individuals did not go on to have that damage in their central nervous system. So when taken together, it seems that EBV seems almost necessary to develop multiple sclerosis, but it's still not sufficient because, again, 95% of adults have been exposed to Epstein Barr virus, but not 95% of adults have multiple sclerosis. Let's talk about how Epstein Barr virus results in multiple sclerosis. And this is through something called molecular mimicry. I remember this mimicry in nature that was described. Basically, here we have a butterfly that has eyes that are supposed to look like an owl. It's supposed to scare away predators. That's not the mimicry we're talking about. This is molecular mimicry. And what happens with molecular mimicry is your body's exposed to a pathogen or virus. And that's that scary looking worm thing on the right in this picture. And your body sees these peptides or antigens that are proteins that your body recognizes and starts to produce antibodies against to start attacking. Now in this example, this is a nerve on the left with this blue myelin. That's what is targeted and stripped away when people have an MS attack. It's a demyelinating process. That myelin gets damaged. And you can see that on the myelin in this picture, they have the same red dots that are there on the virus. Your body has proteins that are similar to what is present in some viruses. And now the antibody doesn't know what to do. And what it ends up doing is attacking both. It attacks the virus. In this case, we're talking about Epstein Barr virus, and it attacks the myelin. So that's how we think that molecular mimicry occurs and how it creates these autoimmune processes. How did they study this? They took CSF. This is another big article that came out. This was in Nature, and it also came out in 2022. So 2022 was a big year for Epstein Barr virus and MS. They took CSF, or cerebrospinal fluid, and blood from individuals with MS, and they screened it against, they looked for the antibodies that are present in that CSF and looked at which proteins in viruses does that attach to. And they found that it does attach to this protein called EBNA1, or Epstein Barr virus nuclear antigen 1. And that was the only protein that they really saw an association that the proteins in the CSF are binding to that. They then looked at the proteomes in the body, so basically the library of proteins that are present in your human body. They looked at over 16,000 proteins and saw that it also binds to a protein called GlialCAM, which is glial cell adhesion molecule. And that is a protein that is found in oligodendrocytes and in myelin. So oligodendrocytes are the cells that produce myelin in the central nervous system. And they show that there basically is this cross-reactivity. These proteins that are being produced in individuals with MS in their cerebral spinal fluid not only bind to EBVNA1, but they also bind to this GlialCAM. So this is, again, exciting in finding out that there is actually some chemistry and biochemistry here that is showing a link from Epstein Barr virus to multiple sclerosis. They also found that 20 to 25% of individuals with MS have these cross-reactive antibodies. So what does this mean going forward? They're looking at this, and they're actually coming up with some potential therapies targeting B cells that are infected with Epstein Barr virus. Maybe we can have a targeted response and just attack cells that have Epstein Barr virus. There's a lot of talk about vaccines. What happens if we make a vaccine against Epstein Barr virus? This could be really exciting. Maybe that will help prevent MS in 20, 30 years. Maybe there'll be new cases. Dr. Katz and I will have to get new jobs, but that's okay, we'll take that. So let's talk a little bit about prodrome. What is a prodrome? Prodrome are non-specific symptoms that occur before the presentation of a disease. We talk a lot about this with other disease processes, so migraines, maybe the day or a couple of hours before a migraine happens, people just feel off, they don't feel right, They might be sick to their stomach. We see it in viral syndromes as well. Before someone develops a flu or comes down with COVID, maybe they just feel off for a day or two before then. But we also see it with MS. And some of this might be related to that Epstein Barr virus. We showed that EBV, when people develop MS, have increased neurofilament light chain in their serum, suggesting inflammation in the brain. So maybe there's this inflammatory stage where you don't have full-on MS, but you have these prodromal syndromes where you just don't feel quite right. Here's a pretty big study from Canada that looked at the 5 years before someone was diagnosed with MS and looked at their physician and hospital visits. So based on claims data based on diagnosis codes, they found that individuals had 4 times more claims for nervous system visits in the 5 years before their MS diagnosis. They were 92% more likely to have ill-defined symptoms and signs and have visits for that. They were also 70% more likely to have musculoskeletal claims and 53% more likely to have mental health visits. They also had 14% lower pregnancy encounters. When you look at specialist visits specifically, within that 5 years before diagnosis, they were 9 times more likely to see neurologists, 3 times more likely to see neurosurgeons and physiatrists. There was an 80% increase in urology visits, and then ophthalmology, ENT, and psychiatry visits were also increased. Not only did they see an increase in the utilization of healthcare visits in hospitals and physician visits, but they saw that there were increased medication use as well. So medications such as musculoskeletal system drugs, such as baclofen, nervous system drugs, such as gabapentin, but also other medications such as genitourinary system medications. There were other findings in the study as well. The closer to an MS diagnosis, the greater the increase in visits and hospitalizations and medication use. So specifically, that 1 year before their MS diagnosis, they were seeing doctors a lot and using a lot of new medications. They were looking for answers and trying to figure out what's going on with them. There were also less pregnancies the closer they got to the MS diagnosis. And this kind of makes sense. If you don't feel right, you're having these odd symptoms, you might hold off on having a family until you have it figured out. They also found more comorbidities. So we already know that multiple sclerosis is associated with mood and anxiety disorders, but this is showing that even before the diagnosis of MS, people are more likely to have depression and anxiety, 24% versus 15%. There was a Danish study that looked at this as well and found that 40% of individuals have depression and anxiety 2 years before their MS diagnosis. Migraine has increased, fibromyalgia has increased, irritable bowel syndrome has increased. I think the mood and anxiety piece is particularly important because we think that there could be this inflammatory process. We already mentioned that there's increased neurofilament light chain. We know that Epstein Barr virus is kind of playing this role in causing this inflammation. And when people get depression and anxiety, it may not just be, oh, I have multiple sclerosis, I'm sad about that, or I have multiple sclerosis, I'm anxious about what's going to happen next. We think that there's probably some biology here, chemistry changing, inflammation changing, that is predisposing them to have that illness, separate from just any thoughts that they may have about their disease. And this kind of goes in line with this concept of invisible symptoms. So when someone has multiple sclerosis, you may not see their whole disease. You may just see the tip of the iceberg. If they're not using a cane or a walker or a wheelchair, oftentimes people may not know that they have multiple sclerosis. I always ask my new patients when they come into my office, hey, do you know anyone that has MS? And a lot of people say no. And I say, I don't think you're right. I bet you do know people with MS. You just don't know they have MS. And one thing that I've learned over the years is that if you want to make someone with MS angry or frustrated, you tell them, hey, you look good, you look great, you look normal. A lot of people don't feel normal. They have all these symptoms that are hidden under the water, and that can be really frustrating for them. And it really affects quality of life. And I think this all goes along with that prodrome period. People are having these invisible symptoms even before they're diagnosed. And that brings up the question about diagnosis in general. It can be really difficult to diagnose someone with multiple sclerosis if they don't have the stereotypical attack, if they don't have the optic neuritis, if they don't have a transverse myelitis where they have numbness or weakness on one side of their body. It can be really challenging. And actually, we were just talking to a gentleman today that was talking about their loved one that they went from doctor to doctor, or their primary care doctor kept on saying that, hey, this is something completely it's a B12 deficiency or something like that. And it wasn't until they saw another doctor that they said, something's not right here, and they sent them to a neurologist and they got diagnosed, but it took a while. We hear that all the time. I'd say the converse is also true. I have patients that come to me and say, I have fatigue, I have insomnia, I have nerve pain, and I Googled it, and it says I have multiple sclerosis, and then I do an MRI, and I don't see evidence of multiple sclerosis. So I see it on both ends, that a lot of people are looking for those answers, and they come to me, and unfortunately, I can't give them answers all the time. So now I'm going to switch gears a little bit and talk about early and aggressive treatment. So we just talked about that there's damage going on early on in the disease, right? There's this neurofilament light chain that shows neuroaxonal damage. Should we treat early? How aggressive should we be? The concept of aggressive treatment, it really goes back to, do we do what's called escalation therapy? Do we start with a platform therapy, which is kind of like those old school injectable therapies, and then progress to maybe a different therapy, and then finally go to the really highly effective therapies? Or do we start highly effective right away? And if insurance companies had their way, we would always do escalation therapy. But that's not what we always do. And there are a lot of observational studies that have looked at this. So this was a multinational observational study with over 1,500 patients. And they looked at various medications and saw how long does it take before people develop secondary progressive MS or have significant progression in their disability. And it showed that in the medications that they assessed, glatiramer acetate, fingolimod, natalizumab or Tysabri, alemtuzumab or Lemtrada, that all these medications help decrease disability progression. But then they broke it up and looked at medications that were more effective versus medications that were less effective. And the patients that had fingolimod, alemtuzumab or natalizumab, which they deemed as a highly effective group, had slower progression than people that were on glatiramer acetate or interferon, which are the, like Rebif and things like that, Avonex. There were other findings in the study as well. Earlier treatment is important. This is kind of common sense, and it's been shown by other studies as well. Individuals that were started, even with the platform therapies, glatiramer acetate and interferon, were less likely to have progression if they were started early on in their disease, within 5 years of their disease onset. We also know that earlier escalation is better. So if someone is on a platform therapy and they do end up getting a more effective therapy, that if they were escalated within the first 5 years of being on the therapy, they were less likely to have conversion to secondary progressive MS. There are additional observational studies. This is a Welsh observational study where they compared people that were on early intensive therapy, which they described as alemtuzumab or natalizumab, and compared to people that got escalation therapy. And those that had that early intensive therapy were less likely to develop sustained disability. This is another large study from the MS-based and Swedish MS registries, and they looked at starting high efficacy treatment either early on or late. So individuals that received therapy early within the first 2 years of disease onset were less likely to have disease progression than those that did start those therapies but didn't start them until 4 to 6 years after their disease onset. In the pivotal trials for ocrelizumab, they looked at relapsing patients with multiple sclerosis and compared an active comparator. So they were using interferon beta, which is Rebif, and they were comparing it to ocrelizumab and looking at disability progression for up to 2 years. So that's the left half of the screen before you get to the dotted lines is what happened in the pivotal trials. What they saw is that there was a difference in disability progression, and those on interferon beta were more likely to have disability progression than those that were treated with ocrelizumab. That was at 2 years. They then offered an open label extension period where everyone that was on interferon beta was allowed to switch over to ocrelizumab, and those on ocrelizumab were allowed to stay on ocrelizumab. And what they saw is that for the next 3 years, those lines became parallel. So instead of having worse disability in the people that were originally on interferon, they evened out and they just had similar levels of disease progression. However, they never caught up to the people that were originally on that Ocrevus originally. So those first 2 years really mattered, and people were unable to catch up in terms of disability progression. If I flip it around and talk about it in a more positive light, some individuals on ocrelizumab had disability improvement. And people on Ocrevus were more likely to have disability improvement than people on interferon beta. When they had the open label extension, the same thing happened. People on the interferon group originally were unable to catch up in terms of disability improvement. So we do know that early treatment is important and that aggressive treatment is important. We have more to come. The big complaint with a lot of these trials are they are observational, meaning that people were not randomized. They didn't say, okay, you go on highly effective treatment, you go on a less effective treatment, and let's see where we are in 5 years. They didn't do that. It was all observational based on what their doctors prescribed or what their preferences were. So we have some randomized trials coming out, hopefully in the next couple of years, called Treat MS and Deliver MS, and hopefully we'll have more answers and more ammunition to fight with insurance companies on about trying to get people on these highly effective therapies.